About 10% of Americans struggle with addiction to drugs and alcohol. Not surprisingly, so do 8 to 12% of physicians. That means the doctor making your diagnosis, or worse, operating on you, could be under the influence. He or she could be an impaired physician. Welcome to Insights. I'm Dick Goldberg. Today we're going to explore how serious this issue is and what is being done about it. With us today is Dr. Michael Miller. Dr. Miller is the medical director of the Harrington Recovery Center at Rogers Memorial Hospital in Milwaukee. He's a board-certified addiction psychiatrist who recently served as the president of the American Society of Addiction Medicine. He also helped lead, for 12 years, Physicians Health in Wisconsin, dealing with these very issues. Michael, thanks very much for joining us. Is 10% a realistic figure for doctors in terms of trouble with drugs and alcohol?
Well, it is. It's not a realistic number for the scenario you presented of the doctor you're seeing today in the office or in the operating room could be under the influence while providing you medical care.
Okay.
That is a much, much, much smaller number. But in their lifespan, over the course of their careers, roughly 10% of doctors will have a problem with alcohol or drugs. They certainly can get into treatment. They can be in recovery. That 10% includes not everybody who's actively using now. It's maybe they haven't developed it yet. Maybe they've been in recovery for 20 years. But it is certainly a problem that we need to look to and look at the issue of physicians with health problems, mental health problems, addictive disease problems, other problems that could potentially impair their performance. And the very, very sort of long-winded phrase used now is a potentially impairing health condition. Not that a doctor who has an illness is impaired, but it would have the potential to impair their performance, and it is an important topic.
Well, are doctors any different than the general population in terms of problems with drugs and alcohol?
Well, they're different to this extent, Dick. In the medical workplace, doctors, nurses, pharmacists have access to pharmaceuticals. The rates of unauthorized use, unhealthy use, addictive use, painkillers, tranquilizers, even stimulants, is greater in health professionals than it is in the general public. The rate of alcohol addiction is a little bit less, but the rate of addiction to chemicals overall comes out about the same.
Which is more worrisome?
Oh, I don't know that any is more worrisome. Certainly, the use of drugs in the workplace happens with nurses and physicians. That does happen. I really don't know if anybody knows or could possibly know, except maybe by surveys asking addicted doctors and nurses, what were you more likely to have used in the workplace, a prescription drug diverted from work or alcohol that you'd consume right before you went on duty. But I don't think making that distinction is the important thing. The important thing to know is that physicians and nurses are people first and professionals second. They're subject to the same health problems, mental health, physical health, and addictive disease that the general public is faced with. Genetics are involved in the addiction of over half of the health professionals that have it, just like for over half of the general public that has it. And recovery really is possible and happens. And physician health programs, professional health programs are really important in improving patient safety, reducing risk to the public, helping health professionals with illnesses get rehabilitated and stay healthy. And so we'll be talking about that during this segment.
Well, I get a sense from what you're saying that it's not as dramatic an issue as I posed in the open. But I'm wondering how often does it happen that physicians are high when they're working?
Oh, way under 1%. I mean, just a fraction of 1% of the clinical encounters. So it's not common at all. And there's some reasons for that. One of the things that has been discovered in working with physicians with potentially impairing illness, and certainly there has been a lot of research done, is that when the addiction does encroach into the work environment, that is a person with a very late stage addiction. Doctors certainly care about their patients. They care about their professional status. They want to protect their license. They don't want to do anything to jeopardize their career. And so, quite actually, substance use in the workplace is much more common in blue-collar populations than it is in professional populations. And in health professional populations, it's quite rare.
Well, should we even worry about someone who's not not using on the job, but just in their own time?
Sure we should. Sure we should. Because it certainly can affect somebody's overall emotional state, can affect their cognitive functioning, can make them preoccupied with things outside of the workplace setting, and can impair their physical health as well. We should be concerned about the issue of health professionals having mental health problems and chemical dependency problems. But indeed, the impairments are more with family, with legal status, a drunken driving arrest, with general medical health, developing liver problems or heart problems or what have you. Those happen before it actually gets into the workplace setting. What we do want to do is recognize that treatment works, that recovery is possible, and that our workforce needs should include an attention to helping doctors, helping nurses not leave the profession, be able to be healthy, be in remission for many years, be closely monitored to assure that they're still in remission, and not have to exit the profession. So I think it's an important societal issue overall to make sure that those amongst us who are health professionals with these conditions get help, get back in the saddle, get back using the education and training they have, get back to be the compassionate people they are, and help people with their health needs.
I'd like to zero in, kind of get some clarity on how this is affecting their practice if they're addicted. I'm hearing most of them aren't doing it on the job while they're working, but it still has an impact. If you're a patient, how are you going to suffer if your doctor is using but not on the job?
Well, it could affect sleep, could affect stamina, could affect neurologic function with regard to manual dexterity.
You're talking about operating now, or
Sure.
different procedures?
Any kind of procedures. But actually, the impairment of performance can happen through things like being hungover, but can happen through things that have nothing to do with drugs and alcohol. Quite honestly, a health professional going through major problems in their personal lives can be distracted and not fully bringing all of their talents to bear. Going through a divorce, having a child who's ill. And this is why we encourage physicians not to just look at sort of this tip of the iceberg of people that have very overt problems, their own major depression, their own alcoholism, but look at an overall situation of health and wellness and try to be as healthy as they can be and ask for help from others and get support when they need it and work with a counselor to deal with a life problem or a marital issue so that they're not subpar in their performance simply due to being preoccupied or distracted by something that's bothering them.
How are doctors at helping themselves compared, again, to most folks, knowing when to turn themselves in for help?
Well, I could make a general statement and say that doctors aren't as good as the general public, but that's because it used to be a male-dominated profession. Men aren't good about getting help for themselves. Okay. Women are much better at asking for help for themselves. But in general, we've heard the cliche that doctors aren't very good patients, and that's true. Really believing that they're above it all, believing that they have special abilities to diagnose their own issues and know when they're in trouble, saying that they're so valuable, that they're so busy that they shouldn't leave work and go to the doctor. Physicians in general have lower rates of good self-care than the general public.
Wow.
That's changing now with the younger generation of physicians and with our attention to the overall topic of physician wellness. Doctors are having better work-life balance. They're not overworking themselves. They're getting better sleep. They're engaging in better exercise. And they're sharing with each other how they're feeling, and they're not so stoic. So the demographic changes, the young generation, is doing a better job of self-care than the old generation. I can tell you that.
Side point: do doctors live longer than the general population?
Yes, but that's due to education and socioeconomics.
Okay.
If you look at public health statistics, the biggest predictor of health actually is education and socioeconomics for everyone.
Now, how does a doctor get the treatment? Is it usually they self-refer, or is it someone calling them out on their problem?
Well, spouses certainly can call them out.
Sure.
And spouses can say, honey, you got to do something. This can be for a male or a female physician. Physicians do self-refer, but actually at quite low levels. The
Lower again than the general population?
Yes. In general, what you want to have is something that exists not in many places, is a practice environment, a professional environment that very overtly promotes physician health and encourages people to come forward. Colorado has a wonderful physician health program where 60% of the referrals are self-referrals. And most of them are not for like a major addiction or a major depression, but just for burnout, helping me cope with stress. How do I just have better work-life balance and be a more well-rounded person? Ontario has a wonderful program for physicians. Most states that do have physician health programs, they focus on the illness and not on the wellness. And when a physician has a significant problem, significant depression, post-traumatic stress disorder, bipolar disorder, addictive disorder, it's usually the intervention of someone else that gets them into treatment.
So what is the protocol if you are a doctor and you suspect a peer is in trouble?
Well, the codes of medical ethics say you don't shut up about it. You talk to the person, you express your concerns directly, or you refer them to an entity which can address their needs. Now, in 46 states, there's a formal physician health program. Wisconsin is not one of them right now. The Wisconsin Medical Society had one of the best programs in the country. It was created by my mentor, Roland Harrington. I happen to work at the Harrington Recovery Center that's named in his honor. He ended his career practicing at Rogers Hospital in Oconomowoc, where I practice now. And Dr. Harrington created that program. He was the real leader and invited me to be a member of the managing committee for the program that the Medical Society operated until 2007. I'm actually working now. We're sitting at your studio across the street from the state capitol. We're actually working behind the scenes to see if we can get necessary legislation to establish a new program that would be independent of government, operated by an independent entity, and so Wisconsin again could have a place where everybody would know where to call,
Okay,
what
so
the phone number is.
In these 46 states where it does work, or they have one,
Absolutely.
tell us a little about the protocol, how it goes when a doctor is reluctant, another doctor notices, what happens next, what's the whole deal?
Well, be happy to talk about the whole deal. And it's not just for doctors. The lawyers have a wonderful program for themselves called the Lawyers Assistance Programs. Nurses have programs in some states. Pharmacists definitely in some states. But the movement, if you want to call it a movement, began with physician health programs. And the way it works is very interesting. There is a tremendous amount of volunteerism involved. Back when I was involved with this 20 years ago, there was a group of what we call volunteer interveners who were often recovering themselves, who were willing to become part of an intervention team and go meet with the doctor. Now, again, the lawyers have this. There's a tremendous group of volunteer lawyers who work with the Lawyers Assistance Program in Wisconsin and other states. So what happens is a phone call comes in. And the first thing is the staff wants to try to get some sense, was this a crank call? Was this a unfounded complaint? Some cases, actually, a disgruntled ex-spouse, a former business competitor, or a disgruntled former partner. You do get spurious complaints, but you ask around, try to get some information, try to get the sense of what the situation is, and if there's a sense that the complaint is valid, the party calling in, may spend quite a bit of time talking with the staff. There may be a decision to go talk with the person. And that actually is done through, an arrangement it's not like the television program intervention exactly, but there's some features. You usually arrange for a trusted colleague, oftentimes a spouse, and then some experienced interveners, volunteers, to go sit down and say, can we talk about what we've heard? And is there a possibility that you should go get at least an evaluation to see if there's something to this? And sometimes people will say, oh my goodness, I didn't realize it would come to this, but yes, let's go. Or sometimes they'll be very, very defensive and say, what are you doing here? You're crazy. Of course I'm not going to. But you first start with, can we just make sure that what the diagnosis is? And the physician health program doesn't do the diagnosis. They send you to someone else. Okay. And you go, and then the program will say, we're volunteers, and right now you're voluntary, but you have to understand that we have this information. And we actually have a cooperative arrangement with the licensing board. We are not the licensing board. We want you to understand that we're your friends here. It's better for you to talk to us than talk to the licensing board. But if you stonewall this and you turn us away, and we think that it would be best for you and for the patients you serve for you to investigate this further and get a good diagnostic eval, we can and will bring in the licensure board, and that's what you really don't want to have happen. So let's talk further.
Okay, so let's say they go and they get evaluated, and the evaluation says this person does have problems with drugs and alcohol.
Then they get treatment, can be outpatient, can be residential.
Can they continue working?
Generally, you don't work during the initial treatment phase.
How long is that?
Generally, 90 days to start.
Wow.
Generally,
Isn't
90
that
days.
a trauma for a lot of doctors?
It's a
Leaving,
trauma.
telling their patients they can't come in for 90 days? And
It's a trauma for their family. It's a trauma for their partners who have to cover for them on call. It can be a trauma for the office staff, especially if it was a solo practice. It's a trauma for a lot of people.
wow.
But it's better than having this problem go on. There's actually very interesting literature in my field, addiction medicine, about the significance of the first 90 days of recovery from a substance abuse problem. Why should it be different for doctors? The first 90 days is the highest chance of relapse. The first 90 days is when the initial phase of brain healing occurs. After the initial
Brain healing?
Brain healing.
What do you mean?
Well, the recovery of the brain from the processes of addiction that involve loss of control, preoccupation, the various and sundry features of addiction. But at any rate, it's often really good to establish a 90-day plan of structure. Now, that can be outpatient treatment, okay, not just residential treatment. But some doctors actually go to residential for 6 months.
Wow.
Yeah, but it's certainly possible for doctors to have a wonderful treatment outcome. In general, you began this with a little bit of a scary scenario. What if your doctor today is under the influence?
Guilty.
The flip side of this is that the recovery rates for doctors are almost the highest of anyone. The highest are actually airline pilots, interestingly, but doctors are right behind. 85-90% recovery rate, super response to treatment. So when doctors do have this problem and there is an intervention and they do enter treatment, the chance of them doing well is very high.
How does that compare again to the general public's recovery rate?
General public rates are actually closer to 50-50, and doctors are way up there. A really famous, now famous, I mean it's fairly recent, but it's certainly got a lot of notoriety, study of I think it was 750 physicians in physician health programs from around the country, followed for 5 years, found that when physicians do enroll in these monitoring programs, 75% have 0 episodes of use in the 5-year monitoring span. And of those that have 1 episode of use, 90% of them have only one. So the monitoring that follows treatment is extremely effective in maintaining people's state of wellness and their state of fitness for duty. And it's to such an extent, this will be one of the more surprising things that you will hear in our little chat today, is that there are some clinics whose medical directors specifically recruit recovering physicians, preferentially, because they know they're monitored, they know they're not going to be using, they know they're not going to be surprised, they know they've been through a process of personal recovery and growth that they sort of have their act together. They've looked at some of their demons that no other doctors have done, and they can also be examples to others for their patients, for their peers. A monitored physician is a very safe physician.
Wow. This is a little crude, but do they like have to pee in a cup like athletes and stuff?
Absolutely.
They do?
Absolutely. The technology will evolve more towards saliva testing, but urine testing is the main method. Hair testing is part of it, but yes.
And this is random, I assume. They don't know when it's coming?
Absolutely. Don't know when it's coming, but monitoring involves several aspects. One is a monitoring of your practice. Somebody, when you enter into a monitoring process, you sign a monitoring contract. It's generally for 5 years. And you agree to have your practice monitored, which means that someone who sees you practice, like a colleague or the medical director of your clinic, will submit a report quarterly to the monitoring agency to say, Charlie's showing up, doing good work, reliable, not coming in late, records are up to date, things are looking good, behaviors with staff is okay, no patient complaints. So the practice behavior is solid. You also have a monitoring of treatment. You have the clinician who's seeing the person verify that, yep, we've got weekly visits, Charlie's coming in, he's been very reliable, we're making progress. So there's treatment monitoring. Sometimes that's appended with a self-help monitoring record that the person is attending AA, for instance. But then there's the laboratory monitoring of doing random tests, generally weekly for the first year or two. Can be less often as you get near the end of a 5-year span of monitoring. But laboratory monitoring is a central piece, and again, hair testing has come into the equation these days because it has a longer window of detection. So absolutely, Dick, and it's not crude to say pee in a cup.
Thank you. Is this like, for some doctors, they feel like they're carrying the scarlet letter, they don't want anyone to know they've been through this, or are most doctors pretty open?
You see every variation. Early on, still a lot of shame, a lot of hiding, a lot of concern about, oh my goodness, who will find out? After several years, generally great openness, and even in a patient encounter, I'm recovering from alcoholism. I'm concerned about your drinking. We probably better talk about it.
Yeah, so they're probably in a way better equipped.
Better equipped, indeed.
Yeah,
indeed. And of course, the scenario when the doctor goes to his or her first AA meeting, the doctor walks in and looks around the room and goes, "What are you doing here?"
Right.
Right.
Right now, if we took a snapshot of physicians in America,
yes, sir.
How big is the problem? I would take it it's not a very big problem because you're saying there's such good monitoring and reporting and peer reporting. So how big a problem is it?
Active use in the workplace, actually quite little.
Yeah.
What a statistic that has been around for a long time is that if the monitoring programs in the 46 states, if they are monitoring 1% of licensees at any particular point in time, they've got a pretty good penetration into the extent of the problem in their state. So it's 1% under monitoring at any one time.
Yeah.
Now,
but how do you know how many are having problems but you don't know about? These are being people who have been determined to have the problems.
Right.
But right now, how many are going undetected? We don't know they have a problem, but they have a problem.
Well, you can use the same kind of survey methods for licensed health professionals as you can for the general public to kind of understand rates. One of the interesting articles was actually written by the surgery department here at UW-Madison. We're recording this in Madison, Wisconsin, and a very interesting survey of alums of the surgery residency here. And what's been your experience in the last 5, 10, 15, 30, 40 years since you finished this residency program with your own use of alcohol or drugs? And the rates of unhealthy drinking, not necessarily addictive drinking, were pretty high. So we have some idea of how prevalent this is. Again, there's going to be about a 10% lifetime prevalence of true addiction, and another rate of major depression that's going to be around that.
What about mental health? You've talked to us about drugs and alcohol. What about dealing with mental health? The same protocol?
Well, somewhat same protocols. Certainly some of the behavior associated with addiction that can be more conspicuous. Drunken driving arrests or disorderly conduct incidents or domestic battery incidents happen with intoxication. They don't happen with major depression. May happen with bipolar conditions. So, sometimes there's not the conspicuous attention brought to the issue.
Sure.
And then there's the issue of monitoring. I mean, monitoring for addiction is a lot easier. There's the laboratory component. There's no lab tests for depression and for anxiety, but there is monitoring of treatment adherence and practice behavior and how someone's doing. But yes, the physician health movement, if you want to call it that, began certainly in the 70s, maybe a bit in the 60s, flourishing pretty well in the 80s. Initial focus on alcohol and drugs, expanded to include mental problems, depression, anxiety. Now, in the states that have the most robust programs, deals with issues of cognitive impairment, which certainly is an issue with the aging demographics of physicians. When do doctors know to quit?
Mm-hmm.
When should they quit? What methods do you use to evaluate the cognitive status of a senior physician? So you got cognitive issues. Then you have just general behavioral issues. You're not necessarily diagnosable with bipolar disorder or alcoholism, but your personality is not the best, and you interact poorly with the team, and you're obnoxious, and you yell at your nurses, and you interfere with the cohesion of the health team, and you become what we've come to call the disruptive abusive physician. So those cases end up being identified and referred to monitoring programs.
With the same threat, if you don't cooperate, get some help, the licensing board might pay you a visit?
They sure might, yes.
Now, can you measure success in these kind of things?
Quite honestly, the success in treating addictions is probably as good as treating anything. And the success in treating the folks that are just the disruptive abusive group is a little tougher.
I would think so.
It is.
And how about the seriously depressed doctor?
Again, the seriously depressed doctor will be noticed because they're really going to be slow. Their thinking may be slower. Their record keeping will be off. They may be tardy. They'll look different to their nurse, to their family. Serious depression certainly won't go unnoticed. Milder forms of depression. Again, a lot of docs wear that T-shirt with the S on it and believe that they can go to work despite not being at their best. And they say, oh, I'll just get through it, and it's not that bad.
If we had 100 doctors here in the studio, and we asked them all, have you seen bad behavior in other doctors that isn't drug and alcohol related but mental health related? And what have you done about it? I wonder what the consensus would say.
Well, there's data on that. They would say they've seen it, and have they done anything about it? No. Very, very interestingly, docs are not only not the best at taking care of themselves, they're not the best at being assertive, and docs in general are not very good at conflict resolution.
Wow.
And they generally don't speak up and assert themselves and say to a colleague, what you did just bothers me. They don't say, boy, you really chewed out that nurse. Do you think that's really good for the team here? They don't say, my God, I walked past the room and you were yelling at that patient. Where does that get you? They really steer clear and say, not my problem. Doctors are not good about calling out their peers. They want to avoid the conflict. There's a lot of education required of the profession. And every new cohort that graduates every decade about how, now that you're part of this profession, what's part of professionalism?
Well, who's
taking care of yourself, taking care of your partner, and speaking up.
Well, who does call out the doctor? If it's not their spouse, and if it's not other doctors, who calls them out?
No, it often happens. Nurses in inpatient settings.
Nurses are more assertive. They're willing to call out the doctors.
They actually are, and patients actually, patient complaints.
And can you give any advice to patients listening if they think their doctor is a little problematic?
Well, yes. Don't be like the doctors and be so timid. Realize that what you're doing is helpful. Most people, why did this crazy idea come up? Maybe because I'm looking at the Capitol. The statistics that say that most people think that Congress is the worst place in the world, but they bring their congressman back all the time. My congressman isn't that bad, but Congress is awful.
Right.
So My doctor, oh my goodness, I wouldn't talk about my doctor, okay, but Sally's doctor, okay, I saw the way that doctor carried themselves, okay, but in general.
So there's a reluctance. Patients are reluctant to...
There's a reluctance, but you're doing a good thing. You're doing a wonderful thing to bring this to light. And again, what's the general orientation? Is it a gotcha orientation? Is it we need to run that guy out of town on a rail? Is it we need to sanction that person? Is it that, boy, that person could function better and they'd sure be healthier and happier, and the world, this community would be better if that doc would stop being this way.
Okay, so let's say you're seeing
rehab approach.
You're seeing your family medicine doc, and you're picking up there's something wrong. He's treating you very badly. Whatever. Who do you talk to?
Well, let's talk about the way the world is now. The way the world is now is that, and your listeners know this. They get healthcare services all the time. The minority of doctors now are the doctors of even my generation who did outpatient and inpatient work. So you have doctors that work in the clinic and hospitalists who work in the hospital. And so the ability to detect problems when the doc comes and makes rounds is much less, because most docs don't make rounds. They stay in the clinic. It's very interesting. Docs now actually do work in large systems where there's a medical administration. They're accountable to someone. Quite honestly, in this day and age, there are mechanisms to report docs that are really easy to use. There's patient satisfaction questionnaires. There's people called patient advocates that work for hospitals and clinics. There's just the administrator's
So just
office.
call the clinic or the hospital and say, where do I make a complaint or talk about a concern about a
I want to
doctor?
raise a concern.
Yeah.
I'd like to talk to somebody. And most decent-sized groups have a physician leader who looks at that data, and then they go and they say, Charlie, we got this information from a patient. I think we should have a little talk about that. And it does happen. And that way it's not up to the individual colleague to have the courage, but there's somebody whose job it is to do it, and they do.
Well, my job is to close the program. And
Are we done already?
Already.
Oh my goodness, the time always
you're always
flies
welcome,
when you do
Michael.
this.
You're always welcome to come back. You have such interesting and knowledgeable things to say.
You're very kind.
And I hope you'll join us on the next edition of Insights.